Would straightway start with the topic of serious malaria infection and the intensive care perspective. Almost about 5 million people in Africa and various other countries are exposed to endemic malaria. This is a much more severe problem than H1N1, and a lot of kids die of this simple curable disease. We are all aware of the life cycle of this parasite. It has the human and the mosquito element, and the whole thing really starts with injection of sporozoites into the blood. There is a hepatic stage, and then it invades the RBCs, and that is where the real trouble starts. These cells sludge the blood vessels, and it is essentially a vasculopathy that results out of malarial infections, and that is what really kills the patients. Falciparum is known to be bad because it has a totally different immunogenicity. In fact, the immunology of malarial parasite has been studied in physiology more than in human medicine, and it has a totally different immune reaction. It invokes hardly any cellular immunity, and the humoral immunity that it comes out of malarial antigen is extremely poor. And while the patient is injected with the parasite, and while in fact the parasitemia is going on, we often see development of resistance in the same patient, which could appear as early as 7th day of the illness. This is not seen with any other organism except for the malarial parasite. The features of malaria are a combination of parasitemia, high fever. A lot of it is also attributed to the anti-malarial drugs, and about 20% of patients with malarial fever have secondary infections. WHO criteria for severe malaria are listed in the slide. Coma, hemoglobin less than 5 grams, picture which resembles ARDS, shock are some of the common defining features, and supporting features could be bilirubin more than 5, prostration, and hyperparasitemia with parasite index more than 5. There are some differences between severe malaria in adults and in children. Cough is common in pediatric age group. CNS involvement in form of convulsions are often seen. CNS involvement in the form of sequelae are seen in more than 10% of patients, and hypoglycemia also is common in pediatrics. Whereas adults, about 30% of them have deranged coagulation. In pediatrics, this is not so often seen. Now, the state-of-art diagnosis for malaria is the demonstration of parasite on a slide. But it has its own limitations, and often you see a thin and a thick spear, which should be normally taken for some of these patients, is not done that seriously. A thin slide is 10 times more sensitive in diagnosing this parasite, but you need a better slide for classifying it as whether it's falciparum or vivax. Now there are some advantages of a method of diagnosing this parasite on a slide. The pickup of parasite is as low as 5 to 10 per ml of blood. You can identify species. You can know what is the parasite index. You can stain some pigment into the leukocytes, and this has some prognosticating factors. But then there are a lot of disadvantages. One, it is time consuming. You need a very trained pathologist, and sometimes when you have parasites sequestrated in lungs or spleen and liver, they may not find their way into blood, and you could miss them. With the mixed infection, in almost about 80% of patients, Vivax would suppress falciparum as far as identification blood smear is concerned. And these are some disadvantages of using the slide method. Buffy coat is about 5 to 10 times more useful in identifying a parasite. But then the rapid tests, which are often useful for diagnosing malaria, have been in use for some time. They're easy to perform, but they have their limitations too. Like, look at this patient who is a 6-year-old male child, brought to the hospital at about 8 with history of fever. His QBC test was reported positive for trophozoites of Vivax. He was started on chloroquine. Next day morning, he deteriorates. And in fact, it was difficult to salvage this boy. And at that moment, it was found that he had falciparum. So often it is a mixed infection, which is reported in India from about 8 to 18% of patients. The sufferer is falciparum because falciparum is suppressed by Vivax parasitemia as far as detection is concerned, and more so when you use the rapid diagnostic tests. The present RDTs look into HRP2 and LDH of a parasite and Plasmodium aldoles. They have such high concentration of Vivax that so often falciparum is missed. Now that's about the diagnostic points as far as critical issues are concerned. The drug of choice for any of these serious malarial infections is to use the schizentocidal drugs. Even today, we find that one of the studies presented from South showed that so often the first line drug chosen was not the schizentocidal drug, and what really matters in the prognostication in patients' falciparum malaria is the right drug at the first moment. Now, certain protocols have been devised by WHO. This is for simple malaria, protocol 1. We'll not go in details of this. This is using chloroquine and primaquine after you have excluded G6PD deficiency. What relates to intensive care is these protocols, and the regime that WHO advocates very strongly is the AMP. That is, you must combine artesunate, mefloquine and primaquine in the regime called as AMP. Start with artesunate. Next day, mefloquine, 25 milligrams, 15 plus 10, and followed by primaquine. Now, early treatment failure is if the parasitemia continues for more than 3 days, or if there is some danger signs of malaria in spite of having not detected parasites. Late treatment failure is defined as after 14 days. What also is important is that mefloquine often induces vomiting. If vomiting occurs within 1 hour, then the full dose of mefloquine should be repeated. And this is extremely important. Again, a study from Kerala reported an increase in mortality of almost about 30% because mefloquine was not retained and the second dose was not repeated. So I think these are some important things which would help in salvaging some of our patients. Now, the first dose should be intravenous. Which artesunate to choose? There has not been any documented advantage of one over the other artesunate. So, artesunate 2.4 milligrams per kg could be the loading dose and followed by mefloquine. It is better to avoid intramuscular artesunate, though the difference is not much. Now, these are the various derivatives. Very interesting fact came in light was one of the African studies demonstrated that about 30% of artesunate which was sold in the market was fake drug. Now, we don't know what really happens in our country, but I think we should be watchful of this. If it is 30% in some of those countries, it could be fairly high. in our country. We should be very careful about this. Now, ABC therapy, that is artemisinin-based combination therapy, what the WHO recommends is definition of severe malaria. Now, why do we combine these two drugs? This is because that both of these drugs have a different half-life. Like mefloquine has a longer half-life as compared to artesunate, and as I've said, this is one infection where the parasite could develop resistance right in the first week of starting treatment. And thus, this is a rational combination right in the given patient. Forget about what happens to the others getting infected. And that is how it is recommended that you must combine these two drugs. This demonstrates the development of emergence of resistance in patients who are treated only with mefloquine. They could develop resistance to the parasite in the next 6 to 7 days. Combinations which are not acceptable or found to be useful have been artesunate plus chloroquine and the others which are listed here. Artesunate plus quinine is acceptable but hasn't yielded much better results. But in very desperate situations, one could combine artesunate with quinine. The only disadvantage is there has been an increased risk of cardiotoxicity with combination of artesunate with quinine. Now, what is the indication of drugs like combining sulfa with one of the pyrimethamine derivatives? In fact, the WHO today recommends that this drug almost has no place in the treatment of malaria fever. About 3 years back, in Indian Pediatrics reported Stephen-Johnson syndromes, and one of the commonest cause of use of this combination. In present day, there is hardly any role of this drug, especially so in severe malaria. It's very important to look for G6PD deficiency in patients with malarial fever. Depending on where you belong to, G6PD deficiency could be seen in 10 to 20% of patients with severe malaria. And I feel it's extremely important. So any male child who has hemoglobinuria, while either he has been treated or he is suffering from malaria, one must keep in mind G6PD deficiency. Now, there are about 21 varieties of G6PD. And if you look in the books, almost all the drugs which are listed for the treatment of malaria are known at some point of time to be incriminated in causing G6PD associated hemolysis. But one of the latest TRCs released last year by WHO says quinine in therapeutic doses is safe if you have an associated G6PD deficiency. If G6PD is deficient in patients with severe malaria, is an extremely important comorbid condition, increasing mortality by almost about 10-folds. So I feel it's extremely important to look for this in patients with severe malarial fever. So also is true with patients with severe malaria and methemoglobinemia. This is a dreaded complication which could occur in some of these patients. And this also happens because some of them have received primaquine before they come to us. And this could make our patients severely hypoxemic and could also be associated with increased acute tubular necrosis. So patients who develop hemoglobinuria while being treated with antimalarials or are suffering with severe malarial fever have almost about 30-fold increase in patients with acute renal failure. So if a patient looks slightly bluish black, keep this particular thing in mind. Now, what are the new aspects of treatment of malarial fever? Some of these things which have come up is a combination of artemether lumefantrine. It is a cure rate of 95%, but not recommended in severe malaria. Combination of chlorprogonil with dapsone is one which is available with LabJap. In one of the studies in adult, which came last in Lancet, in patients who had bad cardiovascular status, where quinine was not found to be safe, this combination has been used in patients with ARDS and cerebral malaria in adults. There have been no pediatric studies showing use of lapdog. But this has been found to be fairly useful in patients who were considered contraindicated for any of the other drugs with problems of QT. Again, this combination has not been found useful in patients with severe malaria. So coming to how do we really take care of patients who have bad mild fever, there are two protocols that the WHO really focuses attention to. One is this: intravenous quinine, loading dose of 20 milligrams per kg over 4 to 6 hours. Change to oral quinine as soon as the patient can take orally. Omit loading dose if the patient was given quinine within last 24 hours. And monitor glucose and blood pressure and look for arrhythmias. This is one regime defined as 3A. Is there a place for exchange transfusion? There's been one study which showed that an exchange transfusion is useful, especially if you have an index of parasites more than 15%. Alternative plan could be use of artesunate followed by mefloquine on second or third day. Do not administer these two drugs at the same time. Bad arrhythmias leading to ventricular fibrillation have been reported in about 5 to 6% of patients where artesunate has been combined with mefloquine and patient had severe malaria. So this combination is useful, but one must be very careful in selecting this, that give artesunate and give mefloquine after 24 hours. Most available drugs for malaria induce cardiac side effects, and these could range from a mild change to a really bad prolongation of QT in association with use of haloperidol. So I think we should be very careful in monitoring these patients, and we should put them on a continuous cardiac monitor to look for what's happening to the QT interval. There's not enough evidence to provide a firm recommendation on the definition of hyperparasitemia. So if the parasite index is less than 5%, it doesn't mean that the patient is unlikely to suffer from severe malaria. Venous lactate concentration has been one factor which has been used for prognostic as one of the good prognostic indicators. But again, a study in archives 6 months back refuted this particular issue, and it didn't see much relation between lactate concentration and the fatality with malaria. Now, malaria eradication is not very easy. The good news is there are no mosquito bachao groups. So, you don't have Menka Gandhi here, so we could kill them. But wherever this has also been achieved, it's not been all that successful. But this is the only present modality that we have. I feel a lot of serious attention needs to be put up in treatment of severe malaria. One, early diagnosis and early intervention, proper combination of drugs. And while the patient has been treated, we need to very carefully monitor them for the various complications associated with the drugs. Thank you.